It is now 4 o'clock, and we are going to just go through some of the deep dive introductory slides, just to give some housekeeping notes and some notices that are coming up. I'm having trouble just advancing. Here we go. Right, so first of all, just to thank our team, well, the Blood SA team, led by Professor Stella Berg, Dr. Nicolai Smith, and Mrs. Michaela Brooks. They're all making sure that deep dive happens regularly and efficiently every week. So thank you to them. All the recordings of the sessions can be found on the website, thebloodsa.org.za, under resources. Please make sure that you mute yourself during the presentation, and feel free to add any questions or comments to the chat box, which we will respond at the end of the presentation. CPD points they'll be submitted to the HPCSA for each session, registered South African specifically, so South African attendees. Please ensure you are attending with your own registered Zoom link and not in a group. You attend at least for 1 hour to get CPD points, and that your HPCSA number is entered correctly when you sign up for deep dive. If you have any other questions regarding CPD attendance certificates from another council or country, please email the admin at Blood SA. You can also join the mailing list via their website, or you can also join via the QR code on the screen. Feedback, please. They appreciate any sort of feedback. So at the end, there's an anonymous feedback survey, which they will appreciate if you could complete. Upcoming events. So there's a physicians conference being held at the Protea Hotel Conference Center in Stellenbosch. That is the 4th to the 6th of June this year. And then early bird registration fee is already valid up to starting Friday the 6th of March. Next, the SASMO TACSETS conference that's being held at the Sandton Convention Center, 7 to 9 August. Early bird registration has already opened as well for that. And then the Heme ONC, which is in Cape Town, and that is also the early bird registration was open the 1st of March, and abstracts as well. There'll be a break for Easter, so the next session will be on the 13th of April, where they'll be discussing CLL 2026, what's changed and what still matters. And that will be presented by Dr. Peter de Wit and Dr. Zinat Barad. Right, so without further ado, today's talk is on the American Society of Hematology 2020 guidelines for sickle cell disease transfusion support. And it is my great pleasure to introduce Dr. Stella Chou. She's an associate professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She's also the chief of division of transfusion medicine at the Children's Hospital of Philadelphia. Dr. Chou is internationally recognized for her work at the intersection of transfusion medicine, red cell immunology, and molecular diagnostics, particularly in the care of patients with sickle cell disease. Her research has fundamentally advanced our understanding of red cell alloimmunization, demonstrating that even carefully RH-matched transfusions may not fully prevent antibody formation due to the remarkable genetic diversity within these RH locus. Through her work, she has helped shift transfusion medicine towards precision approach. She's been integrating molecular typing, donor-recipient matching, and genomic technologies to reduce transfusion complications and improve outcomes of patients who depend on chronic transfusion therapy. In addition to her research, Dr. Chou has played a key role in the development of evidence-based practice, including contributing to the American Society of Hematology guidelines on transfusion support in sickle cell disease, which is the topic of our discussion today. A topic that sits at the interface of laboratory hematology, clinical care, and emerging genomic technologies. Dr. Chou, we are delighted to have you join us today. Thank you very much, and we look forward to hearing your insights.
Great, thank you. Thank you for that kind introduction. And I am going to just share my slides. Okay, so you should be able to see my slides now. So today I'll be discussing transfusion support for sickle cell disease. This was the American Society of Hematology 2020 guidelines for sickle cell disease, which I had the privilege of chairing the panel. So these guidelines were published in 2020, and I'll just mention that annually we do a review of the guidelines to see if they are still up to date, which they have been. We wrote one short letter to the editor that updated one recommendation regarding just additional immunosuppressive drugs that are now available, but otherwise these guidelines are still up to date. And here are the authors of the guideline, which I will mention include adult and pediatric hematologists. It also included individuals that represented blood centers. It included patient representatives, and then we had our our biostatistics and epidemiology colleagues as well. The transfusion support guidelines were one of 5 clinical guidelines that ASH put together that same year. And so this is just for reference, other guidelines that also exist for sickle cell disease. And currently we are kicking off guidelines on the management of pregnancy for individuals with sickle cell disease. So how were these guidelines developed? First, a panel was formed. Each guideline panel was formed following these key criteria of having a balance of expertise and close attention to minimization and management of conflicts of interest. Each panel was allowed to choose 10 clinically relevant questions that were generated in what's called the PICO format by using grade criteria, where we have the population, the intervention, the comparison, and the outcome. So for example, a quick PICO question would look like, should automated red cell exchange versus simple transfusion or manual red cell exchange be used for patients with sickle cell disease receiving chronic transfusions? The evidence synthesis was generated for each PICO question via a systematic review of health effects plus resource use, feasibility, acceptability, equity, and patient values and preferences. And we had the Mayo Clinic systematic review team help us with that. And then finally, making the recommendations. These were made by the guideline panel members based on the evidence for all the factors just mentioned. So how do you use these recommendations? They're done using the grade criteria. So for a strong recommendation, the panel recommends. For patients, most individuals would want the intervention. For clinicians, they would feel that most individuals should receive the intervention. For a conditional recommendation, a majority of patients would want the intervention, but some may not. And for clinicians, different choices may be appropriate for different patients. So depending on their values and preferences, and in this case, should use shared decision-making. I will mention, however, that these guidelines covered 10 recommendations focused on different topics, including red cell antigen typing and matching, indications and mode of administration, as well as screening, prevention, and management of alloimmunization, delayed hemolytic transfusion reactions, and iron overload. 9 of the recommendations were conditional, and even though the grade criteria, as I suggested in the previous slide, that when recommendations are conditional, not everyone may want them as a patient, and not everyone who's a clinician would recommend them. However, most of these recommendations were conditional because there was a paucity of direct, high certainty evidence for outcomes of interest. And so without, for instance, randomized clinical trials, it's very hard to have a strong recommendation. And as you know, for alloimmunization and DHCRs, we do not have strong data to support how to manage those because they're relatively rare outcomes, and thus there's no randomized clinical trials to base our recommendations upon. So several recommendations also have moderate resource implications given the cost of transfusion and the requirement for exchange transfusion in certain patient scenarios. So certainly these guidelines were made really in the setting of high income countries and probably don't apply as well to low and middle income countries. So by the end of the session, you should be able to describe recommendations on the prevention and management of alloimmunization, describe recommendations on the prevention and treatment of hemolytic transfusion reactions, and describe recommendations for managing transfusion therapy for patients who require chronic transfusion support, for treatment of acute chest syndrome, and for patients undergoing surgeries requiring general anesthesia. I actually left out the case about the pregnant patient because there will be new pregnancy guidelines forthcoming. So by way of background, most patients with sickle cell disease will have received a blood transfusion by the time they reach adulthood. And practice varies on when an extended red cell antigen profile is obtained, the extent of antigen typing, and whether serologic or molecular methods are used. Acute and delayed hemolytic transfusion reactions are among the most challenging complications of transfusion support in patients with sickle cell disease. And then there's also practice variation in the use and the method of transfusion for the treatment and prevention of complications related to sickle cell disease, such as stroke. So I base each of these recommendations really around cases. So the first case is regarding red cell antigen profiling and prophylactic antigen matching. And so this is a 3-year-old male with hemoglobin SS. He presents to your clinic for an annual visit. A recent transcranial Doppler shows elevated velocities in the right middle cerebral artery. You recommend that he begins a chronic transfusion program. He has not been previously transfused, and you note that he has not had a red cell antigen profile. So what red blood cell antigen profile should you obtain prior to transfusing the patient? A, ABO, and D only by serology, at least ABO, D, and big C, big E, little e, K by serology, or C by genotyping, or D, at least those above, as well as a more extended phenotyping that also includes the KID, Duffy, M&S systems by serology or genotyping. So I'll just give you a moment to think. So we would recommend that at least ABO, D, C, and E, so the RH system, KEL, and then the extended phenotype be performed by serology or genotype. And so this is a recommendation that it should be done by genotype or serology over ABO, RHD typing alone for all patients with sickle cell disease, including all genotypes such as SS, SC, S beta, 0 or plus at the earliest opportunity, so optimally prior to the first transfusion. And again, this is a conditional recommendation with very low certainty in the evidence about effects because there are no randomized clinical trials. An extended red cell antigen profile should include the following antigens at a minimum. Red cell antigen profile should be made available across hospital systems, and a serologic phenotype may be inaccurate if the patient has been transfused in the past 3 months, and so you may turn to a genotype in that scenario, or wait till 3 months from their last transfusion. The panel suggested, this I just realized is a little bit repetitive, but again, the extended red cell antigen profile by genotype or serology. They also included some best practices. So in addition to what I mentioned before, genotyping is preferred for the additional antigen information and increased accuracy for, among other things, C antigen determination and Duffy B antigen matching. So with the genotyping, we can pick up partial big C antigens. And in that case, if the patient doesn't have a conventional big C antigen, when most of us are providing prophylactic big C, big E, and K matching, we will put a patient on prophylactic big C negative matching if they only have a partial big C and no conventional big C. And then for the Duffy B antigen matching, this primarily is important when patients qualify for extended matching beyond RH and K. And if they have the Gaddisite mutation, they don't require to be matched at for Duffy B. So if their red cells do not express Duffy B due to the Gaddisite mutation, other tissues in their body do express Duffy B, so they're not at risk. And so that may help if you're providing extended antigen typed cells, it would be one less antigen you would have to match for. So the rationale for this recommendation was that the extended red cell antigen profile needs to be performed only once. It reduces alloimmunization when used to antigen match patients with blood donors. And it expedites antibody identification and aids donor unit selection when a patient requiring transfusion presents with a positive antibody screen. So this patient, we obtained an extended red blood cell antigen profile by genotyping prior to the child's first transfusion. You can see on the panel on the right shows their extended antigen phenotype. He's scheduled for transfusion tomorrow. So when ordering his blood, the blood bank would like to know which red cell antigens to match for. So now you have the following results. And so here for example, this patient is Duffy null, but the Duffy B null, the Duffy B antigen expression is affected by the gadocyte mutation. So this patient would not be at risk for anti-Duffy B. So you're about to order your transfusion, and which antigens should this patient be matched for? And when we say match, we provide antigen negative units if the patient is negative for that antigen, but may provide antigen negative or positive units if they're antigen positive. So in this patient with sickle cell disease, we would choose ABO and RH and K matched red cells, but a dotted line around choice D, which is an extended match that also matches for Kid, Duffy, big S, and little s. And that's a minority of institutions, but some institutions do provide an extended phenotype matched unit for patients with sickle cell disease rather than just RH and K. And by doing that, there is going to be minimization of the foreign antigen exposure they have, but at least here in the United States, to find units that are matched for an extended phenotype match, we would not be able to do that for all patients with sickle cell disease nationally. Like we just wouldn't have the donor population to support that. So that's why the preferred answer is generally C. So the panel recommends prophylactic red cell antigen matching for RH, which can be big C, big E, or big C, big E, little e. Most institutions do big C, big E matching because most individuals with sickle cell disease are little c and little e positive, as well as K antigen over only ABO and D matching for patients with sickle cell disease receiving transfusions. And this was actually a strong recommendation with moderate certainty in the evidence about effects, which I will dive a little bit deeper into. The extended red cell antigen profile may be determined by genotype or serology, as mentioned by the first recommendation. And the extended red cell antigen matching, where we match for Kid, Duffy, big S, little s, may provide further protection from alloimmunization. But as I mentioned, finding sufficient compatible units may be challenging. Patients that have the GATA mutation in the Duffy gene, which encodes the Duffy antigens, are not at risk of anti-Duffy B and don't require Duffy B negative red cells. And then patients who are identified by genotype with the hybrid RHD D3A CE4-7D or the RHCE CERN alleles, both of those alleles are relatively common in this patient population, encode partial big C antigen. So, and if the patient themselves do not carry a conventional RHC, big C little e, or big C big E allele, then they should be transfused with big C negative red cells to prevent allo-anti-big C development. So again, patients with these alleles have partial big C, and because they're in a sense missing a part of the big C protein, if they get exposed to conventional big C antigen, they may make an anti-big C. And the French group has shown that about 30% of patients do go on to make the anti-big C if they have partial big C only. So the rationale for this recommendation was that alloimmunization incidence in patients with sickle cell disease is the highest of any transfused patient population. Transfusion burden, inflammation, and Rh genetic diversity play a role for this high rate of alloimmunization. And once alloimmunized, it can become difficult and at times impossible to find compatible units for these patients. In addition, they may cause hemolytic transfusion reactions, and thus prevention of antibody formation may be the best route because we can then avoid hemolytic transfusion reactions, avoid difficulty in identifying sufficient antigen negative units, and avoid transfusion delays. So the evidence that went behind this prophylactic RH and K matching recommendation was based on a systematic review that identified 28 studies. There was a total of 2,535 patients included in these 28 studies. And what they found was that only 2 studies had primary observational comparisons directly between patients with sickle cell disease who were transfused with either phenotypically matched red cells that were RHK matched or RH and extended matched, or versus ABO dematched only. But what I'll say is that these 2 papers, which the references are below, were somewhat limited studies in terms of how many patients they had. And you can see the first study had a very low rate of alloimmunization in general. So for RH and K matched, it was 0.053 antibodies per 100 transfusions, which is almost like 1 antibody in 2,000 transfusions, versus ABO and RH alone, which was 0.189 antibodies in 100 transfusions, which is about 1 antibody in 500 transfusions. And then the second one had a much higher rate of alloimmunization. So for Boateng et al., the extended match made 0.9 antibodies per 100 transfusions. So that's about 1 in 110 units transfused. And ABO and D-match alone for them was 3.1 antibodies per 100 units transfused. And so that's like 1 in every 33 units that were issued to patients with sickle cell disease resulted in an antibody. So to comprehensively look at this, what we did was we pulled the data from these single arm studies. And on the right is a graph that we included in the supplemental of the guidelines, which showed basically at the top are studies that had patients who got ABO and D matched only. And then in the middle, you see extended matching or extended or CEK matched. And then at the very bottom is the CEK matched studies. And what we found was that if you had just RH and K matched alone, when we pooled the data from all of these studies, so each of these studies had to tell us how many antibodies, what antibodies they made, and how many units were transfused in that cohort. And what we found was that for RH and K matched, the rate of alloimmunization was 0.4 per 100 units transfused, which is 1 antibody in every 250 units transfused. If you provided extended matched, it was lower. It was 0.25 per 100 units, which is about 1 in, I think, 750 or 800 units. And then if you had ABO and D matched, it was close to 2 per 100 units. So that was, again, 1 antibody per 50 units of red cells that were being transfused. So essentially, RH and K match brought it down to 20% of the rate that we saw with ABO and D matched alone. And so for this recommendation, that was considered a strong level of evidence that we should provide RH and K matched prophylactically for patients with sickle cell disease. And that could be done by either serologic matching or genotypic matching. So the extended red cell antigen profiling is superior to ABO and RHD typing for all patients with sickle cell disease, and we should get that at the earliest opportunity. If possible, red cell antigen genotyping is the preferred method because it gives us more information. Prophylactic red cell antigen matching for RH and K antigens over only ABO and D matching is recommended for patients with sickle cell disease receiving transfusions. And that doesn't have to be chronic transfusions, it's any transfusion, and that's a strong recommendation. And extended matching to include Duffy, KID, and big S, little s further reduces that risk, but it may be challenging to identify sufficient units for this population. So the other thing to consider is that despite serologic matching for Rh antigens, patients remain at risk of forming alloantibodies to the Rh system due to increased prevalence of Rh variants in this patient population. And so if a patient forms an anti-Rh antibody despite Rh matched transfusions, typically this is done serologically, we would recommend that comprehensive Rh genotyping be performed at a reference immunogenomics lab. And so just to a few slides about the Rh blood group system, because it is still the most common antibodies that we see directed against the Rh blood group system. So we have Rhd and Rhce. There are two genes. They actually sit on the same chromosome facing one another with just about 30 kbs of genetic material between them. And they're highly heterogeneous. So for Rhd, there's been over 500 different alleles that have been reported, and for Rhce, over 150 different alleles. And because of their reverse orientation and close proximity, what has happened in this population is that there's been significant gene conversion, which has generated hybrid alleles and proteins in which parts of Rhd have essentially swapped with Rhce and vice versa. Because of this, this creates challenges for short read sequencing. So for short read sequencing, where we're only getting reads somewhere around 200 to 300 base pairs, because there are the swapping of genetic material, if you get short reads, the computer program won't know whether to align it with Rhd or Rhce. In addition, the variants cause expression of partial Rh antigens, where basically there's a loss of an epitope on the Rh protein, and sometimes it can actually generate what's called new antigens, so antigens that we don't typically express from Rhd and Rhce if you just have the conventional alleles. And while Rh variants occur in about 1% of Europeans, they're much more frequent in Africans. We've shown that about 85% of our population that's of African descent has at least one allele that's not considered conventional. So this is an example of the Rh variant. So as I mentioned before, this is the hybrid gene where exons 4 to 7 in blue came from the CE gene. And this allele actually is considered an Rhd allele, but does not express any Rh protein, but expresses a partial big C antigen. So this is what it would look like if you thought about it at the protein level. Rh is a multi-pass protein. And the phenotype for this allele would be D negative and partial big C positive. Oftentimes, when you have one variant on Rhd, it'll be linked to a variant on Rhce. And so these two alleles are commonly linked. This is the Rhce little c little e s allele. And what this allele encodes is an additional change at position 336, which then causes the patient to have a partial little c and a partial little e expressed. It also causes them to lose what's considered a high prevalence Rh antigen, HRB. So these patients that have the 733G change that causes this one amino acid difference are now lacking this high prevalence HRB antigen, and actually now also express what we call a new antigen, even though it's not new, V as well as VS. So variant alleles can encode partial antigens, they can cause loss of high prevalence antigens and or generate novel antigens. And again, very common in patients and donors of African descent. So we've seen Rh alloimmunization despite Rh matched red cells, and that is serologic Rh matched red cells. They're the most common despite standard serologic matching. We found that 30% of Rh antibodies could probably be attributed to the patient's own variant Rh genotype. So for instance, in this example, this patient may have is big E negative, little e positive, and has two Rhce little c little e alleles that are variant alleles. And if exposed to, say, conventional little c little e, they can form what is considered an allo anti-little e because they are become immunized to an epitope that they themselves don't express. We also think that Rh variant on the donor red cells has been an underappreciated risk factor, primarily because to find sufficient CEK matched red cells for our patient population, at least in the United States, we rely heavily on a donor population that's also of African descent. And then lastly, precise Rh antibody identification is often difficult to identify because of these variants, and that's something else to keep in mind. So the second case is addressing hemolytic transfusion reactions. This is a 34-year-old patient with hemoglobin S beta 0 thalassemia who develops fever, dark urine, and flank pain a week after a transfusion for preoperative preparation. His hemoglobin is 5.6, which is 2 grams per deciliter lower than his pre-transfusion hemoglobin. The antibody screen is positive, but no antibody specificity is identified by the blood bank. So what is the best first step in his management? So in this case, we would recommend steroids and IVIG. The recommendation from the ASH panel was that immunosuppressive therapy, whether it's IVIG, steroids, rituximab, and/or eculizumab, over no immunosuppression in patients with sickle cell disease is recommended in the scenario where a patient's having a delayed hemolytic transfusion reaction and there's ongoing hyperhemolysis. And so we will define those. So a DHTR is defined as a significant drop in hemoglobin within 21 days post-transfusion associated with one or more of the following: a new red cell alloantibody, hemoglobinuria, an accelerated hemoglobin S percent increase with a concomitant fall in hemoglobin A percent post-transfusion, and this is oftentimes the laboratory study that helps us the most, relative reticulocytopenia or reticulocytosis from baseline, a significant rise in their LDH from baseline, and exclusion of an alternative cause. For hyperhemolysis, that's generally defined as a rapid hemoglobin decline to below the pre-transfusion level and a rapid decline of the post-transfusion hemoglobin A percent level. So the case I described, they had a rapid hemoglobin decline to below the pre-transfusion level, and so considered to be in a hyperhemolytic crisis. And so in patients with life-threatening hemolysis, immunosuppressive therapy should be initiated promptly. The potential harm of not providing immunosuppressive therapy to an individual experiencing a DHTR with ongoing hyperhemolysis is possible, but very unpredictable. So first line is considered IVIG and high-dose steroids. Second line would be eculizumab, and that's because there is definitely a complement-mediated component to alloimmunization and DHTRs. And then in terms of rituximab, it's primarily indicated for potential prevention of additional alloantibody formation in patients who may require further transfusion. So for instance, a patient who may have had a stroke, had a delayed hemolytic transfusion reaction, and you managed that current delayed hemolytic transfusion reaction. But in this case, if we didn't find an antibody specificity, you would probably want to treat that patient with rituximab, knowing that you are going to likely put this patient on chronic transfusion going forward. When no antibody specificity is identified, avoidance of further transfusion is recommended unless patients are experiencing life-threatening anemia. So if a transfusion is warranted, you could consider extended matched red cells. So the patient now has had 3 similar episodes. Going forward, the best course of action for this patient who has a history of delayed hemolytic transfusion reactions would be to manage with the following. Choose all that apply. No additional precautions, delay transfusion, ABO-RH and extended matched red cell units, steroids and IVIG, or rituximab greater than 4 weeks prior to transfusion for preoperative preparation. So this is a patient who now has shown us that they've had repetitive delayed hemolytic transfusion reactions. And so in this case, we would choose to give them ABO-RH and extended matched red cell units, use steroids and IVIG surrounding their next transfusion, and also if they were going to have the time knowing that they were, say, going to have a surgery and we just wanted to do preoperative preparation and require transfusion, we would treat them with rituximab at least 4 weeks prior to that transfusion. So in this case, with an acute need for transfusion and a high risk of acute hemolytic transfusion reaction, or with a history of multiple reactions, immunosuppressive therapy is recommended over no immunosuppressive therapy in patients with sickle cell disease. Of course, ongoing discussion is needed to weigh the potential benefits and harms associated with transfusion versus the impact of ongoing life-threatening anemia. So there's certainly shared decision-making. And to consider the respective mechanism of action for the choice of therapy. So IVIG and steroids, typically if they're having ongoing hemolysis or you're about to transfuse them currently, to consider rituximab if you have time and you want to deplete their B cells and prevent them from further immunization events. And then again, a shared decision-making process is critical. Overall, these are rare clinical situations in which patients are experiencing life-threatening anemia and oftentimes require immediate red cell transfusion and or compatible blood cannot be found. So for instance, patients with alloantibodies for whom antigen negative blood is unavailable. That's more in the case of they've made a antibody to a high prevalence antigen. Not so much if we just can't find CEK negative units and we have to wait a few hours. It's more in the case where we know that even if we waited a day, we might still not be able to find them compatible units. And or have a history of repeated episodes of severe hemolytic transfusion reactions with or without an antibody specificity, even when the compatible blood is available. The morbidity and mortality associated with acute and delayed hemolytic transfusion reactions is weighed against the potential adverse effects that are typically experienced with these immunosuppressive agents. And interventions aimed at inhibiting antibody-mediated hemolysis, such as IVIG and steroids, may be more effective in preventing potential acute hemolytic transfusion reactions, whereas efforts to prevent a delayed hemolytic transfusion reaction may benefit from an immunosuppression that mitigates new alloantibody production, such as steroids and rituximab. So in summary of the management and prevention of hemolytic transfusion reactions, acute and delayed hemolytic transfusion reactions are among the most challenging complications of transfusion support in patients with sickle cell disease. Immunosuppressive therapy should be used for patients with sickle cell disease with a delayed hemolytic transfusion reaction and ongoing hyperhemolysis, and with an acute need for transfusion and at high risk of acute hemolytic transfusion reaction, or with a history of multiple reactions and you're worried about another delayed hemolytic transfusion reaction. And so the last case is centered around our approach to transfusions in chronic and acute settings. So this is an 8-year-old patient with hemoglobin SS who had a sleep study showing sleep apnea and needs a tonsillectomy and adenoidectomy. The ENT surgeon has asked for preoperative management recommendations with regards to a transfusion plan. His baseline hemoglobin is 7 grams per deciliter. The procedure will take a little over 1 hour. And so the best response is no transfusion needed, B, red cell exchange, automated or manual, C, simple transfusion, or D, 1.5x maintenance IV hydration 12 hours prior to surgery. So in this case, we would recommend a simple transfusion. So the panel suggests preoperative transfusion over no preoperative transfusion in patients with sickle cell disease undergoing surgeries requiring general anesthesia that's lasting greater than 1 hour. This was a conditional recommendation with very low certainty in the evidence about effects, again, because there are no randomized clinical trials. Decision-making should be individualized based on the patient's sickle cell disease genotype, the risk level of surgery, the baseline total hemoglobin, complications the patients may have had with prior transfusions, and disease severity. It's ideal to have a total hemoglobin level of greater than 9 grams per deciliter prior to surgery. And for patients who have a high baseline hemoglobin level, greater than 9 to 10 grams per deciliter, generally then we would provide red cell exchange instead of simple transfusion for that preoperative transfusion episode, mostly to prevent hyperviscosity. So surgical intervention results in increased mortality and morbidity in patients with sickle cell disease and an increased risk of postoperative pain crisis and acute chest syndrome. treating with preoperative blood transfusion reduces those risks of postoperative complications. It's most beneficial in patients who are undergoing high-risk surgery, which is including cardiac surgery or neurosurgery, patients with a low preoperative hemoglobin that's less than 9 grams per deciliter, and patients with a more severe genotype, such as hemoglobin SS and S beta 0 thal, or who have shown that they have a severe phenotype by their symptomatology. Preoperative transfusion is less beneficial in patients who are undergoing low-risk surgery, patients with a higher hemoglobin level greater than 10, or a high hemoglobin F level, or those with a milder genotype, or phenotype such as hemoglobin SC. And the TAP study really looked mostly at SS patients and had a very small proportion of SC patients. And so that's where these this set of rationale that we put in the guidelines came from. So now that same patient is now 12 years old and presents to the ER with right-sided stroke, right-sided hemiplegia. His MRI shows findings consistent with an ischemic stroke. He was exchange transfused acutely and will require chronic red cell transfusions as an outpatient. Your center offers simple transfusion, manual red cell exchange, and automated red cell exchange. So which program should this patient be initiated on? A, simple transfusion, B, manual red cell exchange, or C, automated red cell exchange? So for this patient, automated red cell exchange would be preferred, but simple transfusion with iron chelation could also be an option. So the panel in general recommends using automated red cell exchange over simple transfusion or manual red cell exchange in patients with sickle cell disease who receive chronic blood transfusions. This is, again, a conditional recommendation with very low certainty in the evidence about effects, again, because there's no randomized clinical trials. Consideration should be given to the clinical indication for which they're undergoing chronic transfusion, their baseline and target total hemoglobin, hemoglobin S percent, the patient age, and patient preferences. Patient age, mostly because even if we're doing a manual red cell exchange, we try to do that with peripheral access and not having to put a line. And so the younger patients are a little bit more difficult to do it with peripheral access. We also consider iron overload status and their iron chelation compliance, the feasibility, and then also the availability of compatible red cells, since red cell exchange typically does require significantly more red cell units than simple transfusion. So when considering the mode of chronic transfusion therapy between simple transfusion, manual red cell exchange, and automated red cell exchange, simple transfusion can typically be done with peripheral venous access, whereas manual and automated red cell exchange may require an indwelling central catheter that then puts patients at risk for infectious complications and thrombotic complications. Simple transfusion requires the fewest red cell exposures, whereas automated requires the highest red cell exposures, and manual red cell exchange is intermediate. Simple transfusion does come with iron loading that is inevitable and would require iron chelation, whereas automated red cell exchange generally results in minimal iron loading, and manual red cell exchange is intermediate. Simple transfusion, you have the risk of potential circulatory overload and potential hyperviscosity, whereas automated red cell exchange, it maintains isovolemia, but it does require a specialized device and personnel. And then manual red cell exchange does minimize those blood volume shifts, but it still does require trained personnel. So those are just some of the considerations. The evidence for this recommendation was that there was 14 comparative observational studies that had 652 patients total. 9 of the studies compared automated red cell exchange to simple transfusion, and 6 of those studies compared automated red cell exchange to manual red cell exchange. Compared to simple transfusion, automated red cell exchange was associated with increased red cell unit requirement, which is not surprising, but it was not associated with increased alloimmunization or adverse transfusion reactions. Automated red cell exchange was associated with lower levels of iron overload, and it also increased the odds of achieving the desired pre-procedure hemoglobin S with shorter procedure duration and increased intervals between the procedures compared to simple and manual red cell exchange. So we achieved the goal hemoglobin S maintenance better with the automated red cell exchange. So a summary of the mode of chronic transfusion therapy compared to simple transfusion, the primary potential benefit of red cell exchange is the reduced iron overload. Compared to manual red cell exchange, the main benefits of automated red cell exchange are improved hemoglobin S suppression, reduced procedure time, and reduced procedure frequency, with no significant evidence of increased risk, specifically red cell alloimmunization. Simple transfusion may be preferred over red cell exchange for young patients with small total blood volume. So certainly those that are under the age of 10, typically we start them on simple transfusion before moving them to automated red cell exchange. Patients who are highly alloimmunized due to the availability of red cell units, and patients who would require an indwelling catheter, we may continue to do simple transfusion with iron chelation rather than choosing the catheter. So again, shared decision-making with the patient and the family. So now your 12-year-old patient has missed several transfusion appointments for secondary stroke prophylaxis. He presents to the emergency room with fever and cough. His chest X-ray shows a right middle lobe infiltrate, and oxygen saturation is 89%, and his work of breathing is rapidly escalating. You have decided to transfuse him, which is the optimal approach. Simple transfusion, manual red cell exchange, or automated red cell exchange. So in this case, we would consider automated red cell exchange as the best choice. And this recommendation is based on the fact that the panel suggested automated red cell exchange or manual red cell exchange over simple transfusion in patients with sickle cell disease and what's considered severe acute chest syndrome. This was also a conditional recommendation with very low certainty in the evidence about effects. So red cell exchange for rapidly progressive acute chest that's not responding to initial treatment with simple transfusion or with a high pre-transfusion hemoglobin level that precludes simple transfusion is also indicated. This case where the patient's oxygen saturation was 89% would bucket the patient in the severe acute chest syndrome category and therefore recommend an automated red cell exchange. In this recommendation, the panel also suggested either automated red cell exchange, manual red cell exchange, or simple transfusion in patients with sickle cell disease and moderate acute chest syndrome. So this is more of a gray area because there was insufficient evidence to support automated red cell exchange or manual red cell exchange over simple transfusion if they had moderate acute chest. So the guideline panel determined that there's very low certainty of evidence for a net health benefit or harm of red cell exchange compared to simple transfusion to treat moderate or severe acute chest syndrome. The data was quite limited with few publications, relatively few episodes of acute chest that occurred mostly in children, and a high likelihood of indication bias. And although no evidence of benefit from red cell exchange was identified, this didn't imply that such an effect does not exist. And because automated red cell exchange can reduce hemoglobin F levels more rapidly than manual exchange, for those reasons, the panel for severe acute chest syndrome did recommend automated or manual red cell exchange over simple transfusion in patients with sickle cell disease. And then for moderate acute chest syndrome, it could be automated manual red cell exchange or simple transfusion. And then for pre-op transfusion, we do suggest it over no pre-op transfusion in patients with sickle cell disease undergoing surgeries requiring general anesthesia and lasting over 1 hour. So lastly, I just want to mention that there are some additional topics in the guideline. The guidelines have actually non-recommendation about red cell exchange with or without isovolemic hemodilution for chronically transfused patients with sickle cell disease. Because there wasn't sufficient evidence, they made a non-recommendation, meaning you could either choose red cell exchange with isovolemic hemodilution or without isovolemic hemodilution for those that are chronically transfused. There are recommendations regarding screening for transfusional iron overload in patients with a history of transfusion. And then there is also a non-recommendation regarding prophylactic transfusion versus standard transfusion care for pregnant individuals with sickle cell disease. And that's something that will probably be revisited now that there's going to be a specific guideline panel that is being put together this spring to address management of patients with sickle cell disease who are pregnant. In terms of future priorities for research, the guideline panel noted several priorities. One, comparison of serologic versus genotypic matching, notably for the Rh system. Outcomes from immunomodulation used to treat or prevent hemolytic transfusion reactions. The role of red cell transfusion in pregnancy. Optimal management of preoperative transfusion. And because most of the studies that are even available are in the era of not treating as aggressively with hydroxyurea, those recommendations may not be as pertinent now that most patients are on hydroxyurea, at least those that have hemoglobin SS and S beta 0. They also prioritize the comparison of outcomes between simple versus exchange transfusions for patients requiring chronic red cell therapy or for treatment of acute complications. And then data regarding the clinical significance of varying degrees of iron overload in patients with sickle cell disease was also a future priority for research. And then lastly, I just want to again acknowledge the guideline panel team members, which I acknowledged at the beginning. Also the Mayo Clinic Evidence-Based Practice Research Program, who did the systematic reviews. And then much of the slide presentation was also done in collaboration with Amar Zaidi, who is a hematologist at Children's Hospital of Michigan. We put the slide deck together, and this is slightly modified, but the slide deck is available on the ASH website. And if you are interested in seeing more about the ASH sickle cell disease guidelines, there is a link for all the guidelines, including ones that have come about since or on their way. So soon there will be a guideline regarding the use of hydroxyurea that will be published. And with that, I will take any questions.
Thank you, Dr. Chou. I think that you've reminded us that the immune system likes to keep us humble, even when we think that we have matched blood 100%. We have not. So we have some time for questions. There's a few in the chat box, but I think I just want to start off with a question. So one of the challenges that we face in South Africa is balancing extensive genetic diversity with this historical limited donor representation. Many centers in Africa are actually trying to improve those, both the donor representation, lab capability, and but access to large-scale molecular typing still remains limited. So if a country were trying to prioritize its next step between improving donor diversity, expanding extended serological matching, or investing in molecular typing, where do you think the greatest clinical impact would be?
That's tough because I think that all three are really important, but probably I would say diversifying the donor population, because we need those donors to support this particular patient population. I think for the molecular typing, there's actually been so much progress in the past 5 years, so that I think that will come because there are groups that are generating ways to genotype at a much more cost-effective manner. So there are chips that are being developed currently that will not only have things about the red cell antigens, but may have other donor characteristics. For instance, some believe that we should not give donor units that have donors who have G6PD deficiency, for instance, that they may not have as great longevity in vivo once they're transfused. So some of these platforms that are being developed right now have things about donor traits such as G6PD or other attributes that have been shown to make someone a good donor versus a not as good donor. I don't think there's any bad donors. And so that should be on the horizon, in addition to just much more cost-effective ways to do molecular typing for the extended genotype, but also to do the comprehensive Rh genotype. So I think that those things are coming, and will probably converge at the same time as being able to diversify your donor population.
Good, thank you. So if I look at the chats, there's some questions, whether we do extended antigen testing at the Western Cape Blood Service. I can't answer that specifically. I know that the South African Blood Bank Service, you still have to ask them to do an extended panel. So it's not something that is just done. And then there's a question here from Andrew McDonald. Is it a question or is it a comment?
It's a question.
Please go ahead, Andrew.
So thank you for an excellent talk. Just a question. So, I mean, we've got about not a lot of sickle patients, but we've got about 6 adults. So we're an adult unit on a chronic exchange program, some with previous strokes and others for recurrent acute chest syndromes. But we were really struggling to get the HBS down post exchange, and then we started a depletion exchange program. But I see ASH relatively recommends against doing that. So, I mean, as I said, you referenced it very quickly in terms of it's also in the recommendations, but we found it being so much more effective. But now I'm struggling that. I looked at the ASH recommendations the other day, and I saw this, and I'm going, oh my goodness, okay, not great. So maybe an expert comment.
So it actually was a non-recommendation in the sense that because of the limited amount of data that was available, the recommendation was that one could either offer chronic red cell exchange with hemodilution or without hemodilution. So basically, the panel didn't choose with or without isovolemic hemodilution to be superior. I will say that in general, here at CHOP, we do take care of a fair number of young adults as well as adolescents who are on chronic red cell transfusion. And we tend to use isovolemic hemodilution in that patient population because you likely do have a small net effect of using slightly less blood per transfusion. We actually did do a deep analysis of our patients who we had chronically transfused over the last 15 plus years. And we saw that because we're a pediatric institution, we saw that patients who required less than 5 units of blood, if you did isovolemic hemodilution, there was no benefit to it. It didn't decrease the number of units we were using. It didn't decrease our goal of maintaining their hemoglobin S less than 30%. So we typically do the isovolemic dilution only for patients who require at least 5 units of blood, which I imagine in your adult population, you're mostly using at least 5 units of blood per exchange procedure. So I hope that answered your question.
Yep, thank you.
If there's any other questions, please post on the chat. Otherwise, Stella, I'm going to ask you another question. So you mentioned that a lot of the recommendations in the ASH guidelines were conditional. So where do you think the most urgent research gaps lie? I think you mentioned it a bit.
Yeah, I think there's several. I think my own question really is more about matching and whether we can avoid alloimmunization by just improved matching using molecular methods, only because I do think that we are at the cusp of using a lot more molecular diagnostics rather than serologic. And if you think about in terms of just access to care, using DNA-based methods is probably actually more accessible than serologic typing for low and middle income countries because it's DNA extraction, which can be automated, and then using these relatively inexpensive PCR-based assays that are soon going to probably be more commonplace. So I think understanding if we could improve our matching, both by avoiding Rh variants that the patient themselves don't have, but also just being able to know much more about the donor and what we're exposing the patient to, whether we can avoid a high rate of alloimmunization. In part because we find that when patients become alloimmunized, they oftentimes form antibodies in clusters. So they'll make one antibody, and then they make another one, and then another one, and then they might quiet down. It's usually not that they like make one if they're chronically transfused, and then 5 years later make another one. It's usually comes in clusters. So I think prevention is really key.
Better.
Yeah. And then I think we also have to probably do collaborative studies looking at transfusion in pregnant patients with sickle cell disease in different levels of acute chest. So for the moderate acute chest, like, does transfusion really help? We also know that when patients are inflamed, they're also at the highest risk of alloimmunization. So it would be really important to know in moderate acute chest, does transfusing them really make a difference in the outcomes of their acute chest? Does it prevent them going to the ICU or prevent them from becoming severe acute chest syndrome? Or are we adding harm by immunizing patients, by exposing them to blood at a time where they're highly inflamed?
Yeah, no, that makes sense. Thank you. Yeah, I'm not sure. I don't really have too much to say about many alloimmunization cases where I'm from, the institution I'm from. I don't know if anybody else has any comments or share any feedback on anything that they've seen in their sickle cell patients at their institutions. We have obviously state-funded institutions, and then we have private medical institutions here. So it obviously varies depending a lot, how patients get treated, what's available at these centers. But most of all, we usually have, one blood bank service. So, they do provide for both state and private. I see Andrew has his hand up. Please go ahead, Andrew.
Yeah, I'm sorry if I'm monopolizing the conversation. Thanks, Stella.
Please go ahead.
Obviously, you referenced in hyperhemolysis. I mean, not that we see it a lot, but immunosuppression. But the question is, use of does tocilizumab have any role in this situation in an acute event to try and mitigate the drop in HB?
Yes, so we would recommend tocilizumab as well. I think we usually take a stepwise approach. So since the guideline has been published, there have been several additional immunosuppressant agents. So we actually wrote a short update that basically said that we would probably still stick to IVIG and steroids as first line. Eculizumab probably is our second line. And then if they're still not responding, then something like tocilizumab would be third line. And we definitely have seen patients who have severe hemolysis, and probably here I probably only use eculizumab a handful of times, but each time we've used it, it's been in a case where they continue to hemolyze even despite their hemoglobin A now being 0%. So they've hemolyzed all their transfused red cells and they appear to still be hemolyzing. And that's when we've used eculizumab. And it has generally been very successful in like slowing down the hemolysis such that we either can avoid additional transfusion in most cases in those scenarios, or just prevent them from becoming more anemic. I have not had to go beyond eculizumab. I know some others have, and I think my sense is that in adult patients with sickle cell disease, sometimes these hemolytic episodes are much more severe than what we see in children and young adults. But yes, tocilizumab would be like next line.
Okay, great. All right, we have a question. If there's any opinion on hyperhemolysis in non-sickle cell disease patients, is this something that you've seen? So we've considered diagnosis in a patient with primary myelofibrosis and is currently treating a patient with no clear underlying diagnosis. So somebody with hyperhemolysis that's non-sickle cell. Have you seen this before?
We have. We've seen it in thalassemia. So in those cases, I think it's very similar to sickle cell disease, that it's probably heme and complement mediated. So just the breakdown of red cells and free circulating heme seems to, add fuel to the fire as well, and also causes complement activation. So we've at least once used eculizumab in a patient with thalassemia. But what I also try to do in those cases is really look carefully at their antibody evaluation. Oftentimes we find that we don't have an antibody specificity, and it seems like they're hemolyzing their transfused red cells. So usually in those patients, even without sickle cell disease, we'll send the red cell genotype, we'll do a comprehensive Rh genotype to look for the variant, and then we try to send out their plasma samples to our immunohematology reference lab so that they can look, for less common antibodies or an antibody to a low frequency antigen or to a high freq antigen. So things that we can't do ourselves in blood banks. Because if your patient is hemolyzing, then it seems like that's the best chance you'll have to identify what might be the underlying cause. So it's really important to send that current plasma sample to your reference lab. So that's our general approach, is to see if there is an underlying antibody that we ourselves cannot detect, and then to consider extended phenotype match red cells in that scenario, and to consider giving them immunosuppressive therapy as well.
Thank you.
Sure.
I don't see any other questions. I don't know if I hope that answered your question, Dr. Malab. And yeah, I think that it's just past 5, so everyone can get their CPD points. And yeah, it's just to thank you very much for joining us this, morning for you, afternoon for us. Thank you for taking your time and for taking some time out of your day to do this for us. Thank you.
I appreciate it.
And yeah, everybody is saying thank you very much as well in the chats. And yeah. Oh, is there another question?
No, it's just my response to the answer. I mean, I think it was very helpful. We didn't consider doing red cell genotyping and extended antibody testing at this stage, but I think we've already started immunosuppressive therapy as per hyperhemolysis, and yeah. But thanks, answer appreciated.
Thank you. Well, thanks again.
Thank you.
Have a nice evening.
You too. Thanks very much, everyone.